Hi everyone, welcome to the 4D show. I am Dr. Prashant Arun, consultant physician and diabetologist at MV Hospital for Diabetes, Chennai. So today's topic is going to be diabetes and its complications in India. Because when we say diabetes, not many people take it seriously because people with diabetes, they can have diabetic neuropathy, nephropathy, retinopathy, etc. But they don't just understand that even testing for the complications for diabetes is very important, and diabetes is about preventing the complication. But people mostly are only bothered about the numbers. They just want to bring down the fasting postprandial. And when we tell them that it is important to test their feet or eyes, kidney, they just don't want to do it. And most of the people with diabetes, they walk barefoot and they develop some kind of ulcer, and because of the diabetic neuropathy, they don't even know that they have an ulcer, and they get to us only when they are in severe sepsis or the wound has become very bad. Most of them don't even test their kidneys or they don't test their albumin levels, and they actually come only when they are having CKD. So this is the problem, and education stands to be the main part where patients need to be educated about even the complications of diabetes. So I welcome Dr. Swati Srivatswa, consultant physician, Dr. Swati's Diabetes and Metabolic Disorder Clinic, Jaipur. On to you now.
Yeah, good afternoon, everyone. And as Dr. Prashant very rightly pointed out, highlighted the importance of diabetes and its complications, especially in the setting of our country, India, which is different from the other places, as we usually discuss. We have information, we have research, we have so much literature about diabetes elsewhere, but how does it behave in our country? What we have to take care, how we have to be more careful, and in which aspects we are different from others. That is what we have to realize. Yes, can you add my slides? So yes, today we'll be talking on diabetes mellitus and its complications in India. So when we see that in India, diabetes, though it's a global phenomenon, it's a global emerging threat. We know that it's somewhat there are some differences when it comes to diabetes in India. In India, every 1 in 11 adults is living with diabetes. And the important thing we need to know is that 1 in 2 adults who has diabetes is undiagnosed. So, two people having diabetes, one does not know that he has diabetes. That becomes very important. The second number of people living with diabetes in second highest in the world is in India. We have 40 million adults with impaired glucose tolerance, and so it's a huge number of diabetics that we have. And we have to there's a complex interplay of the socioeconomic, demographic, environmental, and genetic factors. So, are Asian Indian people more prone to type 2 diabetes? So, according to the ICMR and India B study, the takeoff point for the increased prevalence of type 2 diabetes among the Asian Indian individuals is early on. It's 25 to 34 years itself, a decade before the Western population. And there is something also with the Asian Indian phenotype. There is an increased insulin resistance, greater abdominal adiposity, lower adiponectin, and higher HSCRP levels. So this phenotype makes Indians to be more prone to diabetes and also more prone to the premature coronary artery disease. So when we talk about complications, we are more worried about the micro and the macrovascular complications of diabetes. So talking about the microvascular complications, talking about diabetic retinopathy. So diabetic retinopathy is an important complication which is caused by the damage of blood vessels in the retina, which is light sensitive tissue at the back of the eye. So in India, diabetic retinopathy is a very important cause of blindness as well as for eye disorders. So that makes it very important to prevent it. Again, diabetic nephropathy is when we talk about the effect of diabetes on the kidneys. So that becomes very important because kidney is a very important organ which is affected by diabetes. In a study from South India, around 19.5% of individuals with newly detected diabetes had neuropathy as compared to 27.8% with known disease. So what do we understand by neuropathy? Neuropathy is when the people have the diabetes affects the nerves. So the diabetes can affect the eyes, it can affect the kidneys, it can affect the nerves. So all these three are called the microvascular complications, and we have to keep on checking regularly for whether the patient with diabetes has developed this at all, and if he has developed, is he progressing or is he improving, and we have to take measures to improve them. So a regular monitoring and a regular treatment of the same is very important if the patient has developed these complications. Then we have some macrovascular complications. What do we mean by macrovascular? We say that what complications affecting the larger vessels of our body, the larger arteries of our body. So these macrovascular complications mainly are the cardiovascular complications. So again, they become very important because coronary artery disease and cerebrovascular disorders all are included in this. And Indians are very much are having an atherogenic milieu. Indians have, and the age, we have a 3 to 4 time increased risk of CAD in Asian Indian individuals as compared to the Western counterparts. Why? Because we have an atherogenic milieu, we have a high insulin resistance, we have an atherogenic dyslipidemia in the form of high levels of triglycerides and small dells and LDL cholesterol, and we have low levels of HDL cholesterol. So in Indians, what happens is that at a BMI which is similar to the Western counterparts, we tend to have a higher insulin resistance and a higher abdominal obesity. And this leads to higher coronary events, higher cerebrovascular accidents at an earlier age and more frequent. So we are more prone to these disorders. Then we have diabetic foot ulcers. What is responsible for that? Both the neuropathy as well as the vascular involvement of the peripheries. Both of these contributes. Neuropathy is very much so. PVD has been found to be somewhat in lesser people in some studies from India. Infections. What about infections? See, India always had the epidemic of communicable disorders in the form of infections and related disorders. Now we have non-communicable diseases also, and this double disease burden is really very much heavy. So we have to be very careful because diabetic patients are more prone to develop infections. If they develop infections, they have more difficult course while they go through the infections. The treatment is also we need to be a little more aggressive. What about tuberculosis? Now, when we talk about diabetes and tuberculosis, this becomes a very important double, a burden to the person because they have these disorders have a bidirectional relationship. See, if a diabetic develops tuberculosis, it is not similar to what a non-diabetic may develop in the form that there may be some atypical features like lower lobe involvement or which may delay the diagnosis. And at the same time, once the patient develops tuberculosis, his glycemic control also becomes haywire. And we know that to control the tuberculosis, we should have a very tight glycemic control. So it becomes very important that we control the diabetes also, and we control the infection also together. Now, what are the treatment strategies for these diabetic patients? See, we need to have one thing we need to remember is that we have to get a good glycemic control as early as possible. And seeing this, there's a metabolic memory that if a person gets control earlier on in his life, he probably will have a good metabolic control for future years to come. And for that, we should have a good therapy in the early phase of the disease. So early initiation of combination therapy becomes very important. We have novel medication therapy, newer drugs coming up like the DPP-4 inhibitors, sitagliptin, sexagliptin, linagliptin, alogliptin, the SGLT2 inhibitors like canagliflozin, dapagliflozin, empagliflozin, and the GLP-1 receptor agonists like liraglutide and semaglutide. So we have these days we have a very good fixed dose combination also of the SGLT2 inhibitors and the DPP-4 inhibitors, and this is a very suitable option for the Indian type 2 diabetic patient because they are safer, they have a rapid control, sustained control, they impact both reduction in insulin resistance and improve the beta cell function, beneficial effect on the body weight, lesser hypoglycemia, reduce pill burden, and cost effective. So, I think my take home message would be that the Asian Indian individuals have a high predisposition to type 2 diabetes mellitus, which develops at a younger age and at a lower BMI than the Western counterparts. We have a higher risk of coronary artery disease, probably a lower risk of microvascular complications. We need to find out more on this. And management of diabetes in India faces many challenges. And however, we need to know both about the lifestyle interventions as well as the therapeutic interventions. Starting a combination therapy in the early period of the diagnosis will help in protecting against both micro and macrovascular complications. So, this is what I would like to convey. Thank you very much for your patient listening.
So that was a wonderful presentation by Dr. Swati. So I guess we'll move on to the question answer session. So the triple drug combinations that are lately available, how are they beneficial in preventing the complications for diabetes? That is when I mean the triple drug combination, the SGLT2 inhibitors, the DPP4 inhibitors with metformin. How is this combination going to be beneficial in preventing the complications for diabetes?
So this is a very important question because we know in our nation that we have a lot of problems which are distinct from the Westerners and the other people. For example, one issue is an issue of compliance. So compliance becomes a very important factor. So probably three very important agents having actions on different different sites in the body while preventing diabetes, and then packed in a single pill. I think that would be very useful to the people and more acceptable. Now, when we talk about this combination, as we know, the SGLT2 inhibitors is a group of drug which is recently much in use because of its so many beneficial effects. Not only it has the effect of very good glucose lowering efficacy. So the glucose lowering efficacy is very good. In addition to that, it has a lot of other factors. For example, it has a beneficial effect on the kidneys in the form of reduction of microalbuminuria, in the form of even benefit in the GFR. So it is a very good drug when we consider from the renal point of view. Similarly, from the cardiac point of view, if you see, it reduces the hospitalization for heart failure. It reduces the heart failure occurrence. So it is again a beneficial drug in patients who are suffering and at high risk from atherosclerotic cardiovascular disease. So when we talk about this drug, it's very much useful. We know that. Then we have the DPP4 inhibitors. They are also very useful. They are weight neutral. And yes, SGLT2 inhibitors cause weight loss also. Again, that is very important. And both these drugs are used. Probably hypoglycemia is not so much of a problem as it used to be when we were using sulfonylureas. So comparatively, we have a very good profile. And then we have metformin. Metformin is a drug which, as we all know, is the first drug which we use whenever we start our treatment with the OHs. So this entire power-packed combination of drugs which have so much good impact on not only the glycemic efficacy, but also a good impact on the complications, on the lesser events of hypoglycemia, weight neutrality, weight loss with SGLT2 inhibitors. Probably it's a very good combination. Now, coming together in a single pill, a very good compliance and a low cost. A low cost also being very important in our setup. I think it gives us a very good offers, a very good drug, a very good treatment option, which will be useful and very much acceptable by our people.
Definitely. So these SGLT2 inhibitors, what are the contraindications for these SGLT2 inhibitors, or which set of patients do we actually not use the SGLT2 inhibitors? Because all the guidelines tell us about the SGLT2 inhibitors, the cardiovascular diseases, but which are the set of patients do we not use the SGLT2 inhibitors?
Yes, so that's very important to know that SGLT2 inhibitors basically they act at the level of the kidneys where they stop the reabsorption of the glucose. So while the kidneys are causing excretion of the glucose and then the kidneys are a reabsorption is occurring, they are inhibiting and causing the excretion of the glucose. So we have to see that the patient should have a good renal function, then only probably the SGLT2 inhibitors will function. So basically, if the GFR is above 45 ml per hour, it is a clear cut, we can use very well. But now, literature, more and more work as it is being done, that literature is showing that even at GFR less than 45 also, probably we can use if it is already on a SGLT2 inhibitor and the GFR falls below 45 up to 30 we can give. So basically we wish to remember, then above, when we want to start an SGLT2 inhibitor, the GFR should be more than 45, then only it will act. It's not that it's going to have any side effect, but probably if the GFR is lesser, it is not going to have any effect at all. So we want the GFR to be more than 45 when we start. But if the patient is already on an SGLT2 inhibitor and the GFR goes a little below 45 also, we can continue till 30. Below that, we cannot do that. So I think this is the one most important set of patients where we have to be careful. Other things that we need to remember is that it does cause some amount of weight loss. It is, and in acute illnesses, as they say. So in acute illnesses, when we have some transient disorder, for example, a dry illness and has to be admitted to the hospital and has to get adequate administration, probably also we, as per the literature till now, suggests that we may need to stop the SGLT2 inhibitor for that short time. But for surgery also, if the patient is already on a SGLT2 inhibitors, wishes to go in for a surgery under general anesthesia, then for that transient period, we need to stop it, because as such, the patient will put on insulin. And then after the patient is getting discharged, again, the patient may be put back on the SGLT2 inhibitors. So these are very small places where we need to. Otherwise, I would not think of any major contraindications to the use of SGLT2 inhibitors.
Inhibitors. And what is your suggestion about metformin and the alpha glucosidase inhibitors in pre-diabetes?
So yes, now pre-diabetes is a very important section where our attention is getting shifting now, because we have a lot of agents for diabetes, and I guess we are doing well now. We are if shifting to the pre-diabetes section, because we don't want the persons who are in the pre-diabetes stage to develop diabetes itself. So prevention aspect becomes very important in the current scenario. Should we use metformin? Yes, it can be used. What is primarily used in pre-diabetes first is the lifestyle modification. So lifestyle modification with the dietary changes, diet which is not very much excess in fats, which is limited in carbohydrates, which has a good protein content, a good fiber content, good amount of hydration, good amount of nuts, good amount, less amount of refined substances, refined foods. So less in refined foods, more in fiber. That is what we all prefer. And a good amount of exercise, as we all know. So lifestyle modification becomes the first. But in that case also, if the patient does progress and the patient has a high risk, probably there is, and the patient is obese, patient has significant insulin resistance, like marks, like for example, he has acanthosis nigricans and other such things, then we can, or the patient is a girl with a PCOS, and in such circumstances where there is a suggestion where metformin may help with regard to insulin resistance, yes, it can be given with a regular monitoring.
Yes. So would you use the GTT HbA1c or the fasting postprandial HbA1c in detecting a person with diabetes? That is the first time when he's coming to you and he wants to know whether he has diabetes or not. Would you recommend him on to doing the GTT HbA1c, or would you do the fasting postprandial HbA1c?
So I think, as per the usual universal guidelines for given by for adults who are non-pregnant, and it's a different case for in pregnancy when we want to consider gestational diabetes and diabetes in pregnancy, gestational diabetes as such, not even diabetes in pregnancy. In gestational diabetes, we go in for the GTT, which is a much better option. Otherwise, fasting, postprandial, and HbA1c, I think would be better. It's my choice that I prefer this. And because I've seen that even patients, we have a subgroup of patients who have impaired fasting glucose much more. Then we may not have a very high postprandial, but we do see impaired fasting glucose quite early on, as was seen in some studies from the south as well. So I would like to pay in more stress on the fasting plasma glucose, the postprandial plasma glucose, and the HbA1c, all three of them, when I wish to define a pre-diabetes stage.
Sure. So, what, like, if people with diabetes, if they can drink, what is the alcohol recommendations, or what is your personal opinion that you would say? Because if a person with diabetes is coming to you and he's a chronic alcoholic and he's a chronic smoker, what would be your opinion to him or your counseling to him whether he can have this number of ml in a week or cut down of smoking into half? Or what is your opinion to your patients who come this way?
Again, that's a very interesting question, Dr. Prashant. I would say that smoking, when it comes to smoking, we have enough literature to suggest that smoking is definitely very much deleterious, not only from the pulmonary and the cardiovascular point of view, but also from the diabetes point of view, because it causes an acceleration of all the complications which the diabetics have. So we have clear evidence to suggest that if a diabetic smokes, then his complication rate, how they develop and how fast they progress, very much get accelerated. And hence smoking is one thing that probably we have to try to convince in whatever way to our patient to quit. So smoking is something I probably would not like to, allow the patient to say, okay, probably you can take lesser number of cigarettes or that. Yes, the patient has to try to quit, because it will cause, because as we know that we are not only worried about the diabetes, that glycemic control, we are also worried about the CAD or the cardiovascular or the cerebrovascular accident he may develop, say 5 years later or 10 years later, and we don't want that. So as you rightly had said in the beginning of the talk, that the complication centric approach and the approach that the patient's course of life becomes better throughout is what we are stressing on, and not just what is the glucose level right now and how the patient feels right now. So smoking is something I would really stress upon, that the patient should quit. With regard to alcohol, yes, patients, because alcohol, when a person takes alcohol, then it's just plain calories that go in, the blood glycemic control goes haywire, as well as the food habits after taking consuming alcohol becomes erroneous, and they become erroneous, and hence the patient can develop complications, like for example, he misses his meal, later on he may go into hypoglycemia as well. So we have to again educate. As you said, education is a very important tool. We have to educate the patient and try to make him quit this as well. But if for some circumstances like social drinking or something, where it becomes very where he's not able to do so, he's not able to quit for some reasons, then we have to advise him to reduce his alcohol intake as less as possible, and to take an alcohol beverage which has the least alcoholic content. Another important thing, he should not be missing his meals any time after that, because what is usually seen is that the patient misses the meal, and then a few hours later the patient develops a hypoglycemic attack. So that also has to be kept in mind.
Sure. The point well taken. Statins in patients with diabetes, and what would your target LDL levels be? Because people with diabetes, every person with diabetes needs statins, or what would your target LDL be?
So that is again a very important issue that you have brought up, is that dyslipidemia. See, when we talk about reduction in complications of diabetes, we have to have a good glycemic control, number one, as we all know. We have to have a good blood pressure level, and we have to have a good lipid profile as well. And we have to have a good weight also, BMI also. So all these things together, brought together, probably will have the best of the results. So talking about the lipid profile, that has to be controlled. And as we know, any one single risk factor also, we have to start statins. Diabetes itself, when it comes automatically, most of the patients of diabetes would require a good statin. And unless there is a very patient who has a very low low LDL and total cholesterol levels without statins as well, there are very few exceptions who are like this. Otherwise, most of them would require. Yes, we need to have, in order to control the atherosclerotic cardiovascular disease progression, we have to have a good, well controlled lipid profile. So, as we usually say, that an LDL below 70 is somewhat that we would target. And as such, as we know, that Indians, in spite of having a proper lipid profile, in spite of having a proper BMI, in spite of all these things, we tend to have more of heart attacks. We tend to have heart attacks earlier on, before, at an age which is earlier on, before than the Western counterparts. So we have to be more careful, and we should be clear about our targets: a good lipid profile, good glycemic control, good blood pressure control, a good diet, good exercise pattern, and a good weight control as well. Everything goes together to control our diabetes and to prevent the complications.
Yes. What would your choice of antihypertensives be in a person with diabetes? And what are the factors you would look for? Because we've got the ARBs, the beta blockers, diuretics. We've got a plethora of drugs when it comes to antihypertensives, diabetes. But what would your choice of antihypertensive be? And what are the factors you'll be looking for?
So yes, we have we have a large range of anti-hyperglycemics. We have a large range of anti-hypertensives as well. And my choice would be, when we talk about diabetes, is we are very much concerned, and we wish to keep a good kidney function, a good cardiac function. And from the renal point of view, albuminuria being a very important factor when it comes to diabetic progression, one may develop albuminuria and diabetic nephropathy. So my choice would be early starting of ARBs and ACE inhibitors. They have a good impact in reduction of albuminuria, and that would be a good choice from which I would think. Beta blockers, again, good drugs, but unawareness issue is there. We have to be careful. But when it comes to coronary arteries, a cardiologist may suggest, and in small doses we may use. Diuretics, again, they may be used, but all the drugs can be used. But the ACE inhibitors and ARBs definitely have an edge over the others when it comes to prevention of progression of diabetic nephropathy.
Yes, definitely. Because complication of diabetes, that's what today's topic is all about. And definitely by giving the ACE and ARB, we'll be able to bring down the proteinuria, bring down the BP, and prevent kidney disease due to diabetes. And definitely, as said above, all your slides, if the presentation was excellent. We wish to see you again with the 4D sessions, Dr. Swati. Thank you. Thank you so much for the presentation.
It was a pleasure being here. Thank you, Dr. Prashant and the 4D, for having me here. Thank you very much.